Well, you don't really want to hear about that, do you? So I'm going to tell you a fairy tale instead. Once upon a time, actually it was a modern fairy tale because this is about 35 years ago. And what was happening was there was a very grim situation. As many fairy tales start off that way, but I guarantee you there's a happy ending. So, the grim setting. Between 5 and 10,000 anesthetic deaths were occurring in the United States every year in operating rooms. Now, these were people who were totally healthy going in. They died not because of their illness, nor because of the surgical procedure, but because of the anesthetic accident. Now, this was pretty extraordinary. This is only 35 years ago. And you would think it would be an easy thing to take care of, but in fact, there was no simple solution. What was happening was most anesthesiologists relied on their clinical skills, and they could tell by looking at the patient in one way or another that they might be losing oxygen or not getting enough oxygen. They would see the blood starting to get a little bit blue or purplish. And the only way they could measure that objectively was to take an arterial blood sample, which is not a very easy thing to do, especially in a baby, and take that sample, have it sent off to the lab, and 5 or 10 minutes later, they would get a result. And if it was 10 minutes or even later, too late. The patient was dead. And there was nothing other than their clinical judgment or the ability to do this test, which really wasn't very practical, to help them in the situation, as the statistics showed. So, who are you going to call? Something had to be done. Well, this was the early 1980s, and what was happening in the early 1980s was the arrival of the digital revolution. And chips were invading our lives in every which way, including in healthcare, though healthcare, as usual, always somewhat behind the times. And there was a group up in Northern California, an anesthesiologist who also was an electrical engineer, got together with some colleagues and formed a company, and their objective was to take a technology that had been used in research and bring it in, and commercialize it into a product you could bring into the operating room, and it could be then used to deal with this problem. And the name of that was pulse oximetry. Now, some of you may be familiar with that name, and some of you may not, but you'll recognize it as I describe it. But the idea of this, and the key element of this, the word oximetry, that tells you what it is. It's a way of measuring oxygen. And the pulse oximetry means you can measure it on a beat-by-beat basis, pulse oximetry. So they design, and what it is that it is a device, and usually it's a sensor you can put on your finger, or a clip you can put on the ear, and that was wired to a device, and on which would show out the digits of the oxygen saturation of the blood. Completely non-invasive, immediate, at the time, from beginning to end, and in a very inexpensive packaging. You think they'd found the solution. Eureka, this is it. Perfect solution, major problem, inexpensive solution, as I said. You think that their key audience, the anesthesiologists, would leap at it. What was the result? That roadblock. The anesthesiologist would not touch it. Go figure. Well, why not? Well, it turns out there were 3 basic reasons. The first is they didn't need it. Now, despite all the evidence to the contrary, they were saying, we don't need this. Our clinical acumen is perfectly good. I can tell whether my patient is deoxygenating. I don't need you to come with some device and tell me what I can do perfectly well. Thank you very much. A certain amount of pride in every profession. They actually didn't want it, which is even more surprising. They didn't want it. Why? Because they did not like the idea that if the patient's blood oxygen was falling down, everybody in the operating room could see it. And this would point to the fact that something was going wrong with the anesthetic, and they didn't want anyone to see that, especially the surgeon. And finally, some of them were so offended by the idea that somehow by making this device, it implied that they weren't good at their clinical activity, then they actually chased the salespeople out. So you have a company with a new product that's perfectly good, in fact, extraordinarily good for the purpose, inexpensive, non-invasive, solves the problem, and the customers say, not only no thanks, but get out. So, shifting gears, meanwhile, where I was in my life at that time, I've been in practice and in clinical research for about 15 years. And what I was increasingly finding that my interest in the arts and writing and theater, etc., which I'd done earlier on, was steadily being crowded out by the growth of my activities in medicine. So I decided that what I was going to do is try and find some kind of balance. And the concept I came up with was, because of what I observed, was there was a really need for something different to happen in medical communication. I essentially came up with the term medical communications. And that was to take good science, good medicine, combine it with good media, and use the qualities of good media to be able to communicate more effectively to whichever particular audience you were talking to. And there was a need for that. So I decided to change course. And I gave up everything I was doing and decided I was going to start something different. So together with a PR professional, I co-founded a new organization, but with a difference. I wanted to take this in a multidisciplinary direction. And the concept was to get people in different disciplines to work on the same problem, because too often these problems are solved or try to be solved within one particular group or profession. And came up over time, got physicians, scientists, writers, editors, video producers, PR people, media relations people, all became part of our group. And we created a mission statement, which tells you everything what we were trying to do. And this is important, each word here is important, was to accelerate the adoption of new technologies. The point was every new technology, and this applies to every new product and in a way every new idea, is that you need to, it gets adopted. You introduce it and over time you get the PR agencies and the ad agencies, the communications groups to help you go through the process of doing what needs to be done to get the product out there. But I was not interested just in that. I wanted to accelerate the slope, steepen the slope of adoption. So I wanted to do it somehow smarter or different from just the usual churning out of the usual stuff. The second part of it was important too, and that the new technologies, I wanted to work on only on new technologies, nothing that was a me too. There are too many me too's that occur, somebody comes up with one good thing and everybody copies it. So a new technology, and the way to find the new technology did not have to be just new, but it had to actually make a difference. It had to enhance healthcare. There had to be a good reason why it was out in the marketplace. If just somebody wanted to make a product, go talk to somebody else. And what defined that enhancement of healthcare? It had to either be better efficacy, better safety, better comfort for the patient, better convenience for the practitioner, and or better economics for the payer. So, back to our fairy tale. We have a company with a significant problem, that they've got a very elegant solution, and nobody wants to take it on. And that's exactly what we're sitting saying, that's the kind of thing we're interested in working on. So we get together and start having interactions and start studying the problem. What's going on here? Why is this technology not being adopted? And we come up with this observation that why is it the perfectly good people who are intelligent, who can understand what's going on, do not do something which is demonstrably in their interest to do it? When you think about it, it's an extraordinary situation. So we determined that the problem here was behavioral. It's not the technology. It was not the problem that didn't exist. It was their behavior. And the question was it the behavior of the anesthesiologists as a group? Was there something, a disorder that they had? Some special anesthesiology blockage? Or was it actually the behavior component of people buying or adopting new technologies was the problem itself? And I'm thinking about it, it turned out, yes, indeed, it was. And what is that problem? Well, resistance to change. And we've talked about that a lot, everybody knows about it. But when you think about resistance to change, it's not just a phenomenon of people, it's a biological imperative. Think about through all the animal kingdom, you'll find animals do not like change. They create their nests, they create their pathways, they create situations around them that give them a degree of comfort. It's their way of protecting themselves, comfortable with their surroundings. Any change to that becomes threatening. So human beings are not any different. So on the personal level, why do people resist change? Well, comfort. We all seek comfort. That's our objective. And we seek comfort even when we organize our homes, whether it's our living rooms or our desks. And if people come and disturb them, rearrange them, they've changed the comfort of our zone, and we get very upset. So comfort is a key element. The other thing is we see no reason to change. We deny the risk exists, that if we didn't change, there was any problem. And we certainly were seeing this with the anesthesiologists in that situation. And then there's fear of changing. People don't like because they're worried about what might the change do. There's also situational situations where, in fact, a change in the environment will change potentially the power of that person or organization. They're used to a certain status quo, and if you change it, their power structure may change. Similarly, their status, self-perceived status, or their status in front of their community or their colleagues. And last but not least, there is the economic status. You change the economic structure, whatever they're involved with, and that can cause them to have economic harm. Well, in our particular fairy tale, you had all of those operating, with a notable exception of the economic, because the economic situation was upside down. At that time, because of these concerns and these deaths occurring, malpractice insurance for anesthesiologists were the highest in the entire medical profession, along with neurosurgeons and OBGYNs. As much, this is now the 80s, as much as $100,000 or more annual premiums for malpractice insurance. So they clearly had an incentive economically to do it, and yet they weren't doing it. They were still rejecting it. Well, this was somewhat interesting, but this also turned out to be the key. The key was, by talking to some medical legal experts, one of the things that we learned about was that there was a standard of practice. Now, commonly in many professions, in many areas, there's a standard of practice. And the concept of this is used that if you have a standard of practice, so long as you, whatever you're doing, are operating within that standard, you cannot be shown to be denying it, and therefore was a major protection against being sued. You were not doing things, you were doing everything you were supposed to do. But the key element was, it turned out that all the standards of practice were focusing on the practice of anesthesiology or other fields, but no one was having a standard of practice to protect the patient. So we took the idea and said, what standard of practice make it a standard of care for safety? And that was the transforming element. The way we did it was we pulled together a group, a multi-constituency. We took all the players, all the potential stakeholders. This included, we had 3 or 4 past presidents of the American Society of Anesthesiologists. We had insurance companies. We had clinical monitor manufacturers. We had the FDA. We had plaintiffs' attorneys representing patients. We had defense attorneys representing the profession or the institution. We pulled them in together, and these are people often at loggerheads with each other, on either side of a legal argument or a table, negotiation, whatever. If all these people are natural enemies, could we find something that they all agreed on? Because we could find something they all agreed on, even they might be fighting each other in other areas, they could at least agree on this. And so we developed what we call the motherhood principle. No one is against motherhood, right? So that's what it actually means. And so we said, essentially going around the table and said, does anyone think that it's acceptable to have between 5,000 and 10,000 healthy people dying every year in the United States in operating rooms? Of course, nobody put up their hand. I said, fine, that's what we're going to focus on then. We will focus on, in fact, doing the right thing and making that our focus, no matter where our particular constituencies were or how our particular individual business was involved, whatever it might be. And so we started to develop standards of care. And we spent roughly 18 months. We met 3 times as a group, and started to write this document in between. And around about the time of the second meeting, we had a cease and desist letter from the American Society of Anesthesiologists. How dare you? Who are you to tell us how to practice our profession? We're the people responsible for that. And we said, well, yes. The problem is you're not doing it. And until you do it, we're going to do it. But you're happy to come and join us. And indeed, to their credit, they did. They came and joined, participated, and as we got to the end, close to the third meeting, we were getting ready to put the document together. They recognized, in the words of the old phrase, that the train was leaving the station, and they could either be on it or under it. And they realized what was happening, And to their credit, they then took it into their organization. And in the fall of 1986, the American Society of Anesthesiology adopted the first standards of practice, standards of care in anesthesiology as a standard of practice for themselves. So, the sequels, we then took that into the various other parts of the healthcare environment where oxygen levels were important. And as we progressed through, we then took it into other medical specialties. In other medical specialties, once the anesthesiologists had done it, they realized this was a good thing to do. Effectively, if they didn't do it, they could be embarrassed by it. But there was a good cause to. They saw the benefits. Someone was paying attention to patient safety. And so it spread very widely. We took it internationally. And in 1992, we actually had formed an international task force, 10 different countries around the world, leading anesthesiologists from each of them crafted a set of standards of safe practice of anesthesia on a worldwide basis, taking account of all the cultural, economic differences. And this was adopted in The Hague, in the Netherlands, in 1992. So, if you're making a movie out of this, you would have storyboards. And so what are the key elements you would have? And this applies not just to a new technology, but to a new product, or even a new idea, or new whatever it may be. The first thing you need to do is educate people about it. And we're all familiar with that. It's the first thing we do. We educate ourselves about whatever it is. Then, if it can be demonstrated, whether it's an actual device or whether it's a case study, you demonstrate that what you've said actually works and actually does what you claim it to work. And then for those who are a little bit more resistant, you then persuade them. You don't just wait for them. You say, look, you really need to pay attention. You focus on those people who are objecting you. But that may not be enough. And as we saw in our particular case, you need to do 2 more things to make this happen. Hopefully you don't get to it, but maybe you do. You have to expose them. You effectively have to embarrass them. And essentially it was recognize that if they don't make a change, someone else is going to expose the fact that they're not making the change and will be embarrassing to them. So in a way unpleasant, but on the other hand, you only go to it if the first 3 have failed. And finally, as we did with the standard care, we coerce them. So if you were pitching this movie to Hollywood, that's how you do it. So do something good, because if you don't do it, they'll get an offer they can't refuse. Well, I promised you a fairy tale ending, and indeed, within 2 years of the standards passing, anesthesia deaths dropped to less than 2 per year. Anesthesia and anesthesia and anesthetic malpractice insurance premiums dropped to the level of family physicians. The problem was solved. So, moral of the story, actually I've got 2. When change beckons, embrace the opportunity, don't reject it. It may be far better for you than you imagine. And if you're the person who's trying to affect the change, when it threatens you, failure threatens, declare an adventure. By the way, if you're interested, my oxygen level right now is 96.